like...
I'm usually so brain dead, but literally, if it's past 5 o'clock at a meeting, I'm like, there's just no way. My brain just does not work. By then, you've like sat through 8 hours of this. It's really hard. It would have to be a very interesting topic.
Hello and welcome to the CME Jeopardy program entitled, Can You Master MASH Diagnosis and Management? This program is supported by an independent educational grant from Novo Nordisk. A few important housekeeping notes for those of you in the room. To answer polling questions, please use the keypad provided. Your responses are anonymous and very important to the outcomes of this program. The information being presented is available online. The link is listed on the sheet in front of you. This sheet also provides links to valuable clinical resources and online educational activities. In order to receive credit, please provide your feedback by completing and submitting the two-sided evaluation form before you leave. The MASH Clinician Handout is yours to keep. This handy tool can be used to facilitate screening and management of MASH. For everyone joining us online, the system will prompt you to answer polling questions. The information presented is located on the right side of your screen under the Handouts tab. The evaluation will automatically open in your web browser following the conclusion of the program. For our live audience, please use the question cards located on your table to ask questions. Ushers will be collecting them throughout the program. If you're online, please submit questions through the Q&A box on the right side of your screen. Now, let's give a warm welcome to our presenters. Dr. Sonal Kumar, Dr. Mazen Noureddin, and Dr. Kymberly Watt. Enjoy the program.
Right out.
Oh, they are on.
Good evening.
That was clearly him.
That was...
That is bright. Wow.
All right, welcome everyone. So let's get started. Thank you all for joining. Tonight's going to be a very interactive and fun night for all of us. Good? Okay. Tonight should be a very fun night, interactive night, so hope you all enjoyed tonight's program. Those were our disclosures. Just before we get started, if you see a slide with this little hand with the ribbon on the finger on it, just pay attention because that's where you will see some important information and you're going to need it later on in the game part of our presentation. These are our learning objectives. We're going to be talking about MASH today. And we're going to start off with just a few polling questions. So the first question, approximately how many patients with MASH do you see per week? And you should have your little clicker on your table in front of you. And the answer is number 1, none, 1 to 5, 6 to 10, 11 to 15, 16 to 20, greater than 20, or you do not manage patients at all. All right, number 2, how long after initiating treatment with resmetirom should you assess therapeutic efficacy? Number 1, 6 weeks, number 2, 3 months, number 3, 6 months, and number 4, 12 months. And number 3, which of the following NITs results indicate a patient is eligible for treatment with resmetirom? Number 1, an ELF score of 10.2 to 11.5. Number 2, MRE score of 2.67 to 3.3 kilopascals. transient elastography 8 to 15 kilopascals, or platelets less than or equal to 140,000. Number 4, which of the following most closely represents the histologic response seen with semaglutide in the ESSENCE trial? Number 1, resolution of MASH but no improvement in fibrosis. Number 2, improvement in fibrosis but no resolution of MASH. Number 3, resolution of MASH and improvement in fibrosis. And number 4, cirrhosis regression. Number 5, a patient with a transient elastography score of 7.6 has poorly controlled type 2 diabetes while on metformin. His BMI is 28 and he's taken lisinopril for hypertension. Which of the following is the most appropriate next step for him to reduce weight and better control his type 2 diabetes? Number 1, switch from metformin to semaglutide. Number 2, suggest increased dose of metformin. Number 3, add tirzepatide to metformin and initiate treatment with resmetirom. And number 4, initiate treatment with resmetirom. Number 6, in approximately what percentage of patients with MASH and cardiometabolic comorbidities do you currently prescribe GLP-1 targeted therapy? Number 1, none. Number 2, 25%. Number 3, 50%. Number 4, 75%. Number 5, 100%. Or number 6, you do not manage patients with MASH. All right, so we'll revisit those same questions at the end of this program, and hopefully if you didn't know the answers or if you were unsure, we'll do our job by teaching you and you will get them all correct by the end. So I'm going to just start off by talking a little bit about the pathophysiologic links to cardiometabolic comorbidities in patients with MASLD and MASH. So we'll start off just by setting the stage and reminding ourselves that we now have a diagnostic pathway and algorithm for diagnosing patients with MASLD. So first you see steatosis on imaging or on biopsy, so that gives them the umbrella diagnosis of steatotic liver disease. But there are multiple things that can cause steatosis in the liver, and so the next step is to determine whether the patient has other cardiometabolic disease or other cardiometabolic risk factors. If the answer is no, then you're not in the MASLD category. You look for other causes of steatosis. If the answer is yes, then you still look for other causes of steatosis. If they don't have anything else going on, there no increased alcohol use or no other causes of steatosis, then they get the diagnosis of MASLD. If there are other causes of steatosis, then they still have MASLD, but then they have a combined etiology. And I think the important thing to note with this sort of diagnostic algorithm or pathway is that, number 1, in order to have a diagnosis of MASLD, you need other cardiometabolic disease or cardiometabolic risk factors. And then number 2 is that there can be other causes of steatosis in addition to having MASLD. And the big one that we think about is alcohol. And it's no longer a diagnosis of exclusion. You can have combined MASLD and alcohol-related steatosis or MET-ALD. And that can play a role in the patient's disease course and affect their risk of disease progression. And we'll touch on that later on in this section as well. So these are the cardiometabolic criteria that we think of when diagnosing someone with MASLD, things that you are very familiar with: overweight, obesity, impaired glucose, hypertension, low HDL, and elevated triglycerides. And you can see the adult and pediatric criteria as well. And MASLD has really been thought of as the hepatic manifestation of the metabolic syndrome. And that's really because the factors and pathways that are associated with metabolic syndrome and with MASLD are very closely related and intertwined. And the exact pathways are complex, so I'm not going to go into the exact details of everything that's going on. But the important thing to note is that it's a bidirectional relationship. And so this is a process that involves multiple organs. It involves the liver, it involves the pancreas, it involves adipose tissue, it involves muscle. And basically what you get is a hepatokine-mediated pro-inflammatory state that results in metabolic derangements. You get cardiovascular dysfunction, beta cell dysfunction, inflammation, insulin resistance, and that increases the patient's risk for metabolic disease. And this just becomes a vicious cycle. So all of these diseases, obesity, type 2 diabetes, cardiovascular disease, MASLD, and MASH, they're very closely related in a bidirectional way. And what that translates to clinically in our patient population is that the prevalence increases for MASLD and MASH in high-risk populations. So if you look at patients with type 2 diabetes, the MASLD prevalence is about 65% in patients with type 2 diabetes compared to about 38% in the general population. In patients with obesity, the MASLD prevalence rises in parallel with the obesity rates. So that's going hand in hand. MASLD is seen in 75% of patients with obesity, and 34% of patients with obesity have MASH. And the comorbidities also play a role in disease progression. So MASLD increases the risk of type 2 diabetes and chronic kidney disease. The longer a patient has type 2 diabetes, the higher the risk of having advanced fibrosis. We say that type 2 diabetes is the strongest risk factor for disease progression in patients with MASLD. And if the diabetes is poorly controlled, it also increases your risk of fibrosis progression. And then the leading cause of death in patients with MASLD and MASH is cardiovascular disease and complications from type 2 diabetes and obesity, not actually liver disease. And so when we are seeing our patients and we're thinking about how to risk assess our patients, we know as gastroenterologists and hepatologists, we want to select out the patients that are at highest risk of disease progression, and those are the patients with the highest risk of having fibrosis or having advanced fibrosis. And cardiometabolic factors play a role in that risk of having advanced fibrosis. So you can see here on the graph that the more cardiometabolic risk factors a patient has, the higher the risk of having advanced fibrosis. And that translates to increased risk of all-cause mortality and then increased risk of cardiovascular mortality. So when you think of the disease spectrum of MASLD, you have steatosis. Patients with steatosis can get steatohepatitis, or the inflammatory progressive form of the disease. You get fibrosis and then ultimately can get to cirrhosis, and that's where we worry about the bad stuff related to the liver, risk of liver decompensation, hepatocellular carcinoma, need for liver transplant, et cetera. So when managing our patients and we risk assess them and or we stage them, we see where they are in that disease spectrum, that really affects how we manage patients or how we think about our patients and what we really should be focusing on. In patients with early stage disease, low levels of fibrosis, MASH, steatosis, that's where we want to focus on the cardiometabolic risk factors. Because again, if the cardiometabolic risk factors are not controlled, they are at higher risk of having disease progression. Now, as their disease progresses, and let's say someone does have advanced fibrosis or cirrhosis, you still want to focus on the cardiometabolic risk factors because you want to control those as much as possible, but we just add on liver-specific care at that time. And then finally, what about MetALD? I mentioned that in the beginning. So MetALD is a separate condition. The presentation can range from more similar to MASLD or more ALD depending on how much alcohol is being consumed. The problem with the MetALD population is that it's not well studied. So oftentimes they're excluded from the clinical trials because we want to remove the alcohol component of the effect of pharmacotherapy. But we're starting to see what happens to this group of patients. And we see that even among excessive drinkers, cardiometabolic factors are still important. Obesity increases the prevalence of cirrhosis and the presence of glycemic dysregulation that influences fibrosis severity. So if you look at the number of cardiometabolic factors that a patient has, in a patient with MetALD, the risk of advanced fibrosis goes up as they have more cardiometabolic factors, and the risk of all-cause mortality also goes up. So with that background, I'm going to hand it over to Dr. Noureddin. He's going to speak about optimizing non-invasive tests and biomarkers in MASH diagnosis and monitoring.
Awesome. Thank you for passing it. Before I start, people are done with dinner. If you have these things, can the green people do this, like each table? Can you do green? The green team, please. Please, if you're green,
Boo.
just...
Boo. Boo.
Green, please. Please. I just wanted to introduce the winning team to Dr. Tim. So, all right, so we're going to talk about optimizing NITs and biomarkers in MASH diagnosis and monitoring. So the NITs, if you're here, you don't know NIT, you should, because out there we're not doing liver biopsy anymore. We do it sometimes, but we're moving away from that. And NITs is the abbreviation for non-invasive testing. That some people call it NITs, some people call it NITs. It's your choice. So first of all, I think the big question when we go out there and our primary care call us and say, should I screen for MASLD or not? And I think it's our responsibility now to tell them screening for MASLD is mandatory. It's in the ASLD, it's in the AGA, it's in the ADA, and ACE, which is the American Association of Clinical Endocrinology. I actually quote the endocrinology literature for primary care because they're more likely to believe that than our guidelines for some reason. But the story is that a few years ago we used not to screen, and then with cost-effective analysis, screening seems to be cost-effective and save lives. And it's not like we're going to go screen 300 million people out there. Rather, we're going to screen who's at risk out there. And the people at risk out there are those with increased metabolic risk factors. When I used to be a fellow, there was a lot of hepatitis C. I used to look at the screen.
That's 100 years ago.
A little bit more. So I used to look at the viral load and liver enzymes. What I tell my fellows now, that you want to look at the patient, how they look, as well as their comorbidities. Liver enzymes is less relevant here. And the high-risk individuals that needs to be screened, so if there's anything you want to transmit to your primary care is this. Those with type 2 diabetes, 2 metabolic risk factors, elevated liver enzymes, and there are others in the guidelines, such as family history of cirrhosis, and of course, if you're suspecting other etiology. And the way they should start with the test that's called FIB4. I'm very sure most of you heard of FIB4 by now, but if you did not, it's age, ALT, AST, and platelet. You grab Google and you do FIB4 calculator, and it's there. Or there are some apps that calculate it for you. After that FIB4, usually the primary care just refer, and you would wish that they would refer with the right number. Sometimes they just refer everyone, and the magic number, and we'll go to it, is 1.3 and higher. So if they want to remember one number, I tell them 1.3 and higher. And sometimes I break it down. It depends on the primary care doctor. And then after that, we have subsequent tests to narrow down who is actually has advanced fibrosis, which is what matters. Why advanced fibrosis matter, or significant advanced fibrosis? Because data show that those with MASLD and F2 and F3 are, of course, cirrhosis, are at increased risk of morbidity and mortality. Those are the people that we target for therapeutics for MASH. However, earlier stages are also important because we need to optimize the metabolic risk factors. So again, this is what I mentioned earlier. So this is the ASLD guidelines. AGA is there. AGA is actually going to come up with another one soon. And the ACE and as well as ADA all have that. The magic number is 1.3. Less than that, they stay with the primary care. They need to optimize the metabolic risk factors. The cardiovascular mortality and morbidity is high in these patients. However, once the categories move to 1.3, 2.67, and more than 2.67, this is when you start worried about advanced fibrosis, significant advanced fibrosis. So what do we do next after that? And most doctors or hepatologists and gastroenterologists in big cities, they do transient elastography. Some of them, they do the ELF test, which is a blood test out there, and it's consistent of these 3 components. And the older guidelines used to talk about 7.7. I think that's going to change over time. We get alert when it's really more than 9.2, and those are usually the F2 and F3 patients. And more than 9.8, those are the people that they're going to advance to cirrhosis, and 11.3 is when the thing hit the fan and the patients are likely to decompensate. So pay attention to this as well. Those are transient elastography numbers. So less than 8 stays with the primary care, 8 to 12. Those are patients, we call them the potential risk for significant fibrosis, and more than 12, this is when you really start suspecting F3, F4. Sometimes there's inaccuracy with transient elastography, especially if you have high BMI. So if you're in a fancy place like the Mayo Clinic, what Dr. Watt is, you get MR elastography. We have it, some people have it, others don't have it. So what do we do if we are not sure about the accuracy? We do two tests to confirm the diagnosis and the stage of fibrosis. Again, this is what we have been talking about. So this is the second step in your clinic, and this is the ASLD guidelines. You're going to see this in your board exams. You're going to gastroenterology recertification. If you're a hepatologist, you will see all these numbers popping out there. Transient elastography, 8 to 12. This is when we start suspecting F2-ish, and more than 12, we started suspecting F3 going to F4. The specific number for transient elastography for cirrhosis is 20, actually. Specific number. They're high sensitivity and high specificity numbers. Those are fancy pictures. Those are, I don't want people to think biopsy anymore, but you remember these stages of fibrosis. So 3 is bridging fibrosis. 4 is when you start seeing the nodules, as well as the fourth circle of cirrhosis. But MR elastography and transient elastography can narrow that down, and that's why we don't use biopsy that much anymore, because with 1, 2 tests, third test, I know what my patient has. But sometimes confusing. But in general, 1, 2 tests, you narrow it down. And those are kind of the numbers you see in MR elastography. You see how the fibrosis is progressing on these pictures down below. And transient elastography, we look at the pictures for accuracy, but we look at what I call my patients, the orange number you really want to focus on. That is fibrosis stage. So there are other techniques. So when you have a patient that is doing transient elastography, it gives you 2 numbers, blue number and an orange number. Blue number is the cap, which is the steatosis. The orange number is stiffness, which correlates with fibrosis. So the blue number on the transient elastography or FibroScan is the amount of fat, steatosis. In MRI techniques, actually, when we put the patient in MR elastography, there's another technique called MR protein density fat fraction. So you get these 2 numbers as well, and it shows you the amount of fat in the liver very, very accurately. And if you read, you need to know it, because if you read our phase 2 studies, not the phase 2As, not the phase 3s, we rely on MR fat fraction a lot, especially if the drug reduces the fat in the liver. It's very accurate, but it's not widely available. And that's why now for clinical practice, we use simple things such as transient elastography, ELF. And again, if you're fancy, like Dr. White, you use MR elastography.
Very fancy.
Very fancy.
Very fancy.
Still, the green team is going to win. So, combining NIT, this has been published over and over and over. So, when in doubt, double down. Again, in doubt, double down. So, FIB4, I consider, Dr. Watt and I were talking earlier, we consider it a test that you need to educate your primary care to save lives with it, so they refer the right patient and not bombard your clinic. We don't want all the way to refer everyone, and we don't want them not to refer. Just that number 1.3. And then when in our clinic we use the tool, we have to know, we rule out other causes of liver disease, we talk about the alcohol, we rule out autoimmune, and then we do transient elastography or ELF, and we narrow it down these patients. Liver biopsy is awful. That's what the slides say. We're not going to go and biopsy 80 million people out there. It's not plausible, right? We need to get smarter in this. Yet it has value. High in ANA, IgGs, elevated. You need to rule out autoimmune hepatitis. You need, if the other etiologies are ruled out, we use it here and there. But not most of us moved away from that. I'm going to just tell you about these slides. Most of us don't use it, because the guidelines put transient elastography numbers of 8 and higher or 10 and higher, depends where you read it, elevated liver enzymes, you kind of fall in the same thing. But if you pull that FibroScan app, it's going to show you the FAST and MAST and Agile 3 and Agile 4. So what's the FAST and MAST? Long story short, those with steatohepatitis, that enter the clinical trials with a certain score of 4 and F2 and higher, again, NASH and F2 and higher, you plug these numbers. Let's take the fast example. You put the amount of fat, steatosis, the cap, the fibrosis, and AST, and it tells you who has, based on the score, NASH or MASH and F2 and higher. MASLD is MRI test, PDFF plus emulsistography per AST. You plug it in there and it gives you Agile 3 and Agile 4 are more for fibrosis, and it's at sound. Agile 3 for F3 and Agile F4, and as you see here, they use the platelet, which is very important for liver doctors. Quickly, the study's head-to-head comparison. This is a French study, showed that the MASLD and FAST are very accurate in this study. Again, if you use them, you can go back to these studies. So, ladies and gentlemen, in summary, the green team is going to win. You need to screen for high-risk population for MASLD, and those are the type 2 diabetics and metabolic risk factors. Less than 1.3 stays with your primary care. Once they come to you, you go for transcatheter elastography or ELF, and when you're down, double down, triple down, and you can even use scores out there that are readily available, and will tell you what patient is. Back to you, Dr. Kumar, I think.
Thank you. All right, so you've seen your patient, you've risk assessed them or determined what stage of disease they have without doing a liver biopsy. You've used your non-invasive tests. So now what about treatment? And it's been a really exciting time for treatment in MASH, because after decades of studying different therapy, we finally had our first drug approved in March of 2024, and this is resmetirom. Resmetirom is a thyroid hormone receptor beta agonist that is liver-directed therapy. So it directly targets genes that promote free fatty acid uptake. And what you see is that it reduces lipotoxicity, it reduces triglycerides and cholesterol, and removes bile acids. And again, this was approved in March of this last year to use in adults with MASH in stage 2 or 3 fibrosis. And again, the important thing to note is that per all the guidelines, despite using biopsies in these clinical trials, we do not need a biopsy to determine if a patient is eligible for treatment with resmetirom. So this is the Maestro-NASH trial. So this was the phase 3 trial that led to the approval of resmetirom, and they had 2 endpoints: MASH resolution with no worsening of fibrosis, and then fibrosis improvement of at least 1 stage. And you can see there were different doses that were studied. The blue is placebo, and then you can see as the dose goes up, you can see a little bit of an increased response. But just to note that it's weight-based dosing, and we'll talk about the dosing in a minute. So the ASLD has actually published really nice guidance on how we should be determining whether a patient is eligible for resmetirom. So you want to make sure, it's great to have this therapy available, but you want to make sure that you're prescribing it to the right patient. So step 1, we want to confirm the diagnosis. We want to exclude other causes of liver disease. And then we want to determine the stage of fibrosis. Again, we do not need a liver biopsy for this, but if for some reason your patient did get a liver biopsy, maybe you were unsure about the diagnosis, you end up doing a biopsy and it shows MASH with stage 2 or 3 fibrosis, that's when you can consider using resmetirom. And then when it comes to the non-invasive test here, you can see that these are the different criteria. And so remember, this was in your pre-test question, so it's going to come up later when you guys have to answer questions, so pay attention. Again, transient elastography, 8 to 15 kilopascals, MRE, 3.1 to 4.4, ELF score, 9.2 to 9.7, and 9.8 to 11.3 if in isolation. And then the FAST MAST or MEFIP score. So if you have any other assessment of fibrosis that shows stage 2 or 3 fibrosis, then you can use that as well. Step 3, you want to make sure that the patient does not have cirrhosis, because it is not indicated for patients with cirrhosis. And you can see the non-invasive tests that are consistent with cirrhosis. And then if they meet all these criteria, you can consider treatment with resmetirom. There's also recommendations on what we should be checking in patients. So at baseline, we want to check baseline liver tests. We want to check the thyroid function, lipid profile if they're on a statin, and you want some assessment of fibrosis. So if you do some way of assessing fibrosis, because that's what you're going to use later on to assess whether they're responding to the treatment as well. And then at 3 months, and 6 months, you want to assess for safety, you want to assess for tolerability, and then at 12 months, that's when we really make the decision on whether a patient is benefiting from the drug. So when you're starting the medication, it's weight-based dosing, 80 milligrams if the patient is less than 100 kilograms. It's 100 milligrams if a patient is 100 kilograms or more. Again, at 3 and 6 months, that's when you want to do treatment monitoring, make sure they're tolerating the medication, make sure they're compliant with the medication, make sure there's no evidence of DILI or anything like that. And then at 12 months, that's when we're going to assess for efficacy. And you can see the different sort of categories of how to determine whether a patient is responding. So if they have worsening of their NITs, and so you're going to use the same NIT that you use to determine eligibility, you're going to use that same test to determine how they're responding. If they have worsening or they have a consistent increase in their liver enzymes, their ALT, that's indicative that the patient may not be responding to the medication, and that's when you would consider stopping. On the flip side of it, if the ALT is improving, you have a transient elastography fibrosis improvement of at least 25% or MRE improvement of at least 20%, then the patient is responding to the medication, and that's when you want to continue it. When the benefit's uncertain, like you don't hit that 25 or 20% in their non-invasive tests, or the ALT is stable, MRE-PDFF had less than 30% reduction, you really have to individualize that decision making. So you have to think about tolerability, you can continue it, you can talk to the patient about whether stabilization is also okay, and then reassess as moving forward. Now, we have other tools in our toolbox. Even though they do not have a FDA indication for treating MASH, GLP-1s are around, and we should consider using them in our patients. So the ASLD has actually put up practice guidance on GLP-1 targeting therapies, and the recommendation is that we consider using semaglutide or liraglutide in patients with MASH without cirrhosis because of the benefits that they have in the other cardiometabolic risk factors that play a role in patients with MASLD and MASH. Semaglutide has demonstrated evidence of MASH resolution and improvement in fibrosis, and this was actually just published in the New England Journal a couple of days ago. And then tirzepatide may be used for patients with type 2 diabetes or obesity with MASLD as well for their benefits in type 2 diabetes and obesity. This was the Essence trial. Again, this is what was published in the New England Journal just a couple of days ago, and this was a 72-week trial that looked at resolution of MASH with no worsening of fibrosis, improvement in fibrosis with no worsening of MASH, and then they also looked at the combined resolution of MASH and improvement in fibrosis. And you can see compared to placebo, semaglutide did better. And then they also saw improvement in weight and cardiometabolic comorbidities. All right, what about tirzepatide? Tirzepatide similarly has been studied in patients with MASH. This is the Synergy NASH trial, and they looked at resolution of MASH with no worsening of fibrosis as their primary endpoint, and you can see they have a dose-dependent response, and at with 15 milligrams of tirzepatide, there was a 62% response in resolution of MASH. And then looking at fibrosis stage, you can see compared to placebo, around 50% response across the doses of tirzepatide. Now, one of the big questions we always get is, can we use GLP-1s and resmetirom? And what I always tell people, it's not an either-or situation. Patients who are on GLP-1s were included in the Maestro-NASH trial as long as they were on a stable dose as GLP-1 for 6 months prior to randomization. So that was included in the resmetirom trial. But there's no real guidance on how we should combine the therapies, and you really just have to use the best judgment. We should treat patients individually. We should think about the importance of weight or fibrosis progression, their comorbidities, and then decide individually which one you want to start, how you want to start with treatment with the patient. What I would say is probably don't start them both at the same time, because if there are any issues with treatment, you don't know which drug it's coming from, but just really individualize the care in terms of which one to start first. And then we also have to remember that surgery is also an option for patients. So this was a study on bariatric surgery in patients with advanced fibrosis. So these are the highest risk patients that are getting bariatric surgery, and you can see after, with paired liver biopsies, after getting bariatric surgery, there is an improvement in fibrosis. And then as gastroenterologists, we're also interested in endoscopic procedures. So there's the endoscopic sleeve gastroplasty, which is not here on the slide, but one of the few trials that actually looked at paired liver biopsies was with the intragastric balloon. And after 6 months, patients had pre and post liver biopsies. You can see that there was a total weight loss of over 10%, and the NAFLD activity score improved in 90% of patients just in 6 months. Fibrosis improved, and MRE detected fibrosis also improved. So also something we can consider and often offer to our patients. All right, and then last talk before the game will be Dr. Watt talking about cardiometabolic comorbidities.
All right. I wanted to congratulate all the self-selective winners that chose the yellow tables to sit at. So good job. We'll ignore my right-handed colleague over here. So we're just going to talk a little bit more, not specifically about MASH itself, but all the other things that we can do about the cardiometabolic comorbidities for these patients, not specifically addressing the actual fibrosis part of things, but everything else about these patients. Tend to be, as you know, high risk as far as the cardiometabolic comorbidities. And of course, weight loss is one of the most important features, whether you're on a medication or not. They still need to have lifestyle changes. The medications don't work on their own in general, but we need to have lifestyle modifications. There are other drugs as well that we should at least review. Can we use these in liver patients? Not everyone's eligible for GLP agents. There's a little bit of data here on orlistat, and Steve Harrison published this a bunch of years ago. Orlistat itself did not have a specific benefit to the liver itself, but the people that lost weight had benefit in the study, so whether they were on orlistat or not. So the weight loss benefits are real, very similar to what we see in all the other weight loss studies. You can also remember there are other FDA-approved medications for weight loss, and that's phentermine, topiramate, Qsymia combination drug. Bupropion, naltrexone has some mild transaminases that have been associated with that in liver patients. The phentermine, the only thing to really think about is the renal dysfunction or Child-Pugh-B score. Patients you'll need to do some dose adjustments. These are generally limited time periods that you're on these medications, usually stop about 12 weeks or so they do have some limitations. And we'll talk a bit more about the GLP agents as well as the SGLT2 inhibitors. There's no major flags on the liver tox. If you're not familiar with that particular website, it's NIH website here that you can look up nearly any medication or supplement or product, and it's actually very, very helpful. So doing the med list review with the patients is a very key part, and that's a very helpful website. A lot of patients are Dr. Googling, and generally Dr. Google will convince you you're going to die by Tuesday. So they're going to come to you and say, can I take this? Or you're going to find out they are taking some of these agents, and these are just a very small number of weight loss herbal products that have been associated with liver toxicity. So again, you can put these into that liver tox website, and that can be very helpful, but at least identifying some of these and noting to the patient that they're not always going to be safe just because they're quote-unquote natural. So GLP agents, I think everyone in the room knows this. You know they're really good at weight loss, widely used now. Very, very common that we're seeing patients on this, and this is actually very beneficial to a lot of our patients, not just for their MASLD and MASH-related benefits. The weight loss itself is going to help all the other cardiometabolic benefits, and you can see with both semaglutide, tirzepatide, really significant weight loss, very successful drugs, and used quite commonly. If someone's already had a bariatric procedure or any kind of procedural-based weight loss therapy. You can still use these agents as well. These bariatric surgeries, they're generally very good at weight loss, but then eventually some people will regain weight. Sometimes you just get insufficient weight loss, and this is where you can actually use these agents, although you would think counterintuitively. Sometimes they've got most of their stomach removed. Is this really going to help you? But there are some studies that do show that you will get some significant weight loss in these patients as well, and so to consider that in some of these more refractory patients. Some of the other benefits of these agents, not just about weight loss, but obviously they started off as anti-diabetic agents, and so the benefits on reducing their insulin resistance and improving their A1C control for both GLP agents that are available for us is very helpful. And obviously when we're talking about MASH, that is also a critical element to avoiding MASH progression. SGLT2 agents, another good anti-diabetic drug, also has a lot of other cardiometabolic benefits, and so when you're probably not the one that's going to be ordering these medications, prescribing these medications, but what you need to do is be permissive and helpful to the PCPs that are doing this. And so I will always have in my note to the physicians to say, if you're going to choose an anti-diabetic drug, choose these agents over insulin, which is going to help people gain weight, right? So, or over the glipizide or those sorts of anti-diabetic drugs. So there's a lot of different benefits to the SGLT2 drugs. There's glycemic control, there's some weight reduction. It's not as profound as the GLP agents, but it's still notable. There's a very definite benefit to cardiovascular outcomes, and I'm sure most of you are aware of that. And a lot of our cardiac patients are already on these medications. There's benefits for renal function. There's even some evidence now on neuroprotection. There's also liver-related benefits, and you can see some of the studies there on specific agents, and most of them are just looking at liver enzyme improvement, maybe some stiffness improvement, and we need a little bit more defined data on this. But these are good agents, at least if someone's going to put someone on an anti-diabetic agent and they can't get coverage for a GLP-1, at least choosing that over some of the other ones is of some benefit. So we also get reduced cardiovascular endpoints. So cardiovascular disease, cardiovascular events, all reduced with GLP-1 agents, both semaglutide and the tirzepatide agents. And it's a 20 to 24% reduction in cardiovascular events. So that's a pretty significant improvement. We've seen from many, many studies over the years, and this is one of the studies from many years ago in gastroenterology that looks at outcomes in MASH, and was previously mentioned earlier tonight, that people with MASH don't necessarily die from liver disease. They're more affected by cardiovascular disease and malignancies. And cardiovascular disease is the major risk for mortality. One of the most important risk reducers is actually statins, which shouldn't be a mystery when we know that cardiovascular outcomes are the major risk of death. And so one of the other things we as gastroenterologists and hepatologists have to do is be very permissive about statins. Almost always it's been stopped because their liver tests are up, or maybe they've noticed to have fatty liver and someone just stops their statin. They need their statin. And the statins are generally safe in these patients. And in fact, if you look at the details of a lot of the studies, maybe they're not showing an actual bona fide benefit to MASH, but they are showing safety and they're showing improvement in liver enzymes, and overall they're of a benefit for mortality in these patients. So be very permissive to the local providers and get them back on their statin. You have to put that in the note or it just doesn't happen. So also a benefit that isn't talked about a whole lot with resmetirom is the anti-lipid benefits. So that's obviously going to help with MASH, but also for our cardiovascular patients that have high lipids. And so there are some additional benefits to the medications that we would even be prescribing as far as cardiometabolic. There's other things that you can suggest to the local provider, you can suggest to the patient, and so probiotics and prebiotics, more importantly, and every gastroenterologist knows fiber is a good prebiotic. Well, it actually can help with BMI. I think many folks probably know that, but it'll also help reduce LDL. So if we're going to have some cardiovascular and cardiometabolic benefits, it's a pretty benign intervention to get people using fiber. So there's other benefits to all the things you're talking to them about. And the one thing we're taking many things away from these patients, right? We tell them don't drink alcohol, stop eating food, give them back their coffee. Coffee is good, right? Cheers. So, and give them lots of coffee. So there's really good benefits to the coffee. It's not the caffeine, it's all the other sort of antioxidants and all the other components to the coffee, and the drip coffee is better than the other coffees. And you can get a reduction, as you can see, in fatty liver and the fatty infiltration. You get a reduction in fibrosis in a couple of studies. These aren't the most, robust studies, but we just like to see that coffee's good. But you also, some people will worry, well, what if they have cardiometabolic issues? Can we give our heart patients coffee? And there's plenty of data in the cardiac literature that coffee is also of benefit to them. Now, if they have SVT or something, maybe don't do it. But you can give them back their coffee. We take so much away from our patients. There are future investigations in a lot of different medications. We're going to see a lot of potential benefits down the road for all of our cardiometabolic issues. New medications coming out. There's going to be combination medications coming out. It's going to probably ultimately, when we're treating MASH patients, it's going to be a lot like heart therapy, where we've got multiple different medications trying to hit different parts of the pathway in the pathogenesis of MASH. And many of those agents are going to have cardiometabolic benefits as well. So we are done with the main part of our session.
Yes.
And now we just have to figure out how the yellows are going to destroy the greens.
And apparently I'm team yellow here.
Yes, excellent.
All right. Oh, okay. Fair and balanced, fair and balanced. All right, so now I hope you all were paying attention, because now you all are going to answer the questions and determine whether the green team wins or the yellow team wins. Okay, so here are the rules. Everyone has been assigned to a team. Dr. Noureddin will be, and Dr. Water, your team leaders. Mazen, your team green. Kim, your team yellow. They will take turns choosing a category and a dollar amount, just like in Jeopardy. Both teams will respond to every question using the keypad at your table. So you don't have to worry about, your team green and team yellow, according to your table that you're sitting at. We will take care on the back end of how you're responding. But I'll ask a question, you will respond, they will talk about the answer afterwards. And then the team that answers the highest percentage of correct answers will win the round. So we did a coin toss before you all got here, and Dr. Noureddin will be starting.
I told you.
All right, so here are our categories. Less pain, more gain, by the book, playing defense, and MASH mishmash. Oh. Okay, so Mazen, you're up first.
Thank you, Alexa. I'll go for less pain, more gain, 600.
Okay, which of the following represents the transient elastography cutoff values for high risk of advanced fibrosis? So you all respond at your table. All right, this is how everybody responded.
That just means they listen to you.
I know, the green.
We've never had that before.
And there's a green, I know. Yeah, the correct answer is 12, more than 12. We talked about the guidelines, the high fibrosis, high likelihood for advanced fibrosis on transient elastography is more than 12. To throw other numbers out there, that Siddiqui paper showed that the high sensitive for cirrhosis is 14, but the high specific is all the way to 20. So this is when we consider, like the highly specific is we really don't want to treat people with MASH agents that they are not tested in cirrhotic. 8 to 12 kind of in between could be F2, and less than 8, this is when the patient stays with the primary care doctor.
Great. All right. Oh, yellow one.
Told
that
ya.
one. Yay.
It's
all right.
right.
Team
It's
yellow,
all right.
you have $600. Okay.
Excellent, excellent,
All
excellent.
All right. Next.
All right, I'm a Canadian hockey player, so we're going to play defense. We'll go at 200.
That's it?
Got to start you off easy.
All right.
All right, which of the following most closely represents the histologic response seen with the semaglutide in the ESSENCE trial?
You know this, Yellow.
I like it. Great, go for it.
We've got aggressive greeners out there. Get them. See, they were listening. This is excellent. All right, so resolution of MASH and improvement in fibrosis was the result of the ESSENCE trial. So good job, everyone.
Green.
Wait, who won that one?
Who won that?
Let's see. Green. Nice
Oh,
job,
yeah.
Green.
That's why I only chose 200.
That's all right.
All right, Team Green 200, Team Yellow 600. All right, next up, Mazen.
Please. All right. I have to have it from you. But let's.
Please read option. I didn't get the rest of it.
Yeah, we have to read the
read
options.
the answer.
Sorry,
Okay.
we will read it. By the book, 400.
Okay, which of the following represents the correct doses for resmetirom initiation based on the patient's weight? Number 1, 60 milligrams if less than 100 kilograms, 80 milligrams if greater than or equal to 100 kilograms. Number 2, 80 milligrams if less than 100 kilograms, and 100 milligrams if greater than or equal to 100 kilograms, and 100 milligrams if less than 100 kilograms, and 120 milligrams if greater than or equal to 100 kilograms. This is why I shouldn't read this. And or number 4, 120 milligrams if less than 100 kilograms, and 140 milligrams if greater than or equal to 100 kilograms. I have no idea what I just read.
Oh, God. That's good.
Nice job, 91%. Who's crushing one? That was you.
Oh, yeah. It's.
I mean, that's.
I'm not repeating the numbers. So, but in general, we say in the United States, it's 100 kilo. Less than 100, you get 80 milligram. More than 100, you get 100 kilogram. What's 100 kilogram in pounds? Sounds very familiar to me, but less than 100 is 80, and more than 100 is 100, and most people got the question correctly, so
Good job.
hopefully the green will win.
Good job, Yellow. I know you did it.
Let's see.
What, like 90-odd% of everyone in the room got it, so there's no way green won. There's no way.
Oh, green.
No way. It's fixed.
Hallelujah.
Absolutely not.
Hallelujah.
All right, next.
All right, we're mishmashing some mash. 600. You're so aggressive.
This is your teammate. You called her aggressive.
She wanted the 800.
All right. Okay.
Okay, which of the following investigational therapy regimens has breakthrough therapy designation for non-cirrhotic MASH? Number 1, semaglutide and zalfermin, survodutide, semaglutide and cilofexor, or dapagliflozin.
Daba what? Oh, we're split here, but
yeah.
the green will win.
Yeah, we'll see.
The green is the right answer.
Green is the right answer. Survodutide is in its phase 3 clinical trials, and it did actually already receive breakthrough designation due to some of its early success. So it's not orderable yet, but it's a new exciting medication that's very potentially going to be an important aspect of MASH treatment down the road, hopefully. I don't know that there's a lot else to say about it at this point, but it was tucked into one of the the slides that you saw earlier. So, yeah, some of you were paying good attention.
Oh, the yellow
And we
people.
know who you were, right?
Show me the money. Show me the money. Yeah. God.
Should have went with
Oh,
800.
look.
You're totally right. You're totally right.
We'll catch up. Let's play defense 600. Let's do it.
Oh, choose again.
So,
Nothing happens. No one gets money.
Okay, let's go to the screen again.
I think you should lose money.
I'll play defense 400. Okay. You're attacking me.
All right.
So wait, do we $1,000? How does that work, Alexa?
$1,000 for what?
Like the 600, 400 choose again? Anyways.
No, you got zero.
I forgot the rules.
Zero. All of the following are true of surgical weight loss, except number 1, it can resolve MASLD or MASH in patients without cirrhosis. Number 2, it has no effect on liver fibrosis. Number 3, it is associated with decreased all-cause mortality. And number 4, it may result in insufficient weight loss.
Oh,
As
we're split.
That's correct.
Yes. So this was tricky because it was the except. So the correct answer, which was the incorrect answer, it has no effect on liver fibrosis. So there are benefits for fibrosis improvement with surgical weight loss. Mazen, how do you feel about bariatric surgery in your patients with MASLD and MASH? Do you recommend it?
I mean, it's very effective, right? Fibrosis actually decreased significantly with bariatric surgery. The cirrhosis data is still a little bit questionable if it does or doesn't, and we can go to that. In the guidelines, they mention it to manage comorbidities, so it's not usual. In my practice, it's not the exact right first line. It's harder to convince patients actually to go to bariatric surgery. With endobariatric, they're more open, but it's not reimbursed. I usually try to talk to about my patients with BMI more than 40, and it's insurance approved. Between 35, 40, I try, but it's harder everyone wants to lose their weight on their own and try it, and a lot of times it doesn't work. But it's very effective, including mortality, all cause of fibrosis, cardiorenal, you name it.
Yeah. And Kim, do you use bariatric surgery in some of your, or recommend bariatric surgery in some of your patients?
I think the higher BMI patients, and obviously, somebody has to be really interested in that. So I'll bring it up. There's not a lot of definite takers, but certainly I think the much higher BMIs are probably going to have a better response to the surgical or procedural based weight loss.
Great. All right.
Yeah.
Yellow wins.
Yeah.
Oh, yellow.
Oh,
Mazen,
look at
you gotta get your tables.
Look at
Fine.
that.
Ah.
All right.
right.
Dr. Watt, you're up.
All right. We're going to do some less pain, more gain, 800 smackers. I'm trainable. I'm trainable.
All right, which of the following metrics indicate a sufficient response to resmetirom? So for transient elastography, at least a 15% drop in liver stiffness. For MRE, at least a 20% drop in liver stiffness. At least a 20% reduction in MRI PDFF, or no significant difference in ALT from baseline.
Ooh, we got a mix.
All right, mix.
See, that was a tough question. Those are kind of nitpicky little differences. So you can see the metrics there. MR elastography, 20% drop. Transient elastography, 25% drop is sort of the recommended metrics. And I think the steatosis was more like 30%.
Yep.
So, yeah, that was a bit of a tough question.
Ah.
Yeah, I don't know if I like
You see?
that.
Uh-huh,
I don't know if I like that.
All right. Mazen.
I'll take it easy on you. Let's do less pain for 200. I can get you.
Oh, free parking. You just got $200.
Boo. Boo. Yeah, they feel sorry for you. It's just not right. It's not right.
All right, you didn't have to answer that.
So do I get to go now?
Yeah, you get to go now.
All right, we'll do
We're
buy,
close.
buy the book 200.
Watch out. We're close.
Buy the book 200. Let's do it. That's because you're cheating.
How long after initiating treatment with resmetirom should therapeutic efficacy be assessed? 6 weeks, 3 months, 6 months, or 12 months?
If we don't get 100% on this,
Yes.
and somehow green wins, I'm running the table at the back there. Take that $200. All right, we've got a little bit of a mix. So it is 12 months. Am I reading this or are you reading it? I'm reading this.
You're reading.
It is 12 months. Yeah, so the recommended time is 12 months. I think it's reasonable to look at things at 6 months, but I wouldn't give up till 12 months. Yeah, nicely done, yellow.
I'd say $200. That's okay.
All right, next.
Let's stay cheap. Mash, 200. And green this time, please.
They don't want to play with you anymore. Are we mishmashing?
Oh,
Aha!
you lost $200.
See, you jinxed yourself by
I'm
cheating.
glad I picked
You
200.
jinxed yourself by cheating.
All right.
You've been whammied,
Lammy.
because that's a verb.
All right.
Is it?
Do I get to go again?
Yeah,
No.
now your turn.
All right, we're playing Defense 800. Bring it on.
All right.
That's long.
Patient with a BMI of 37, LDL of 90, hemoglobin A1C of 7%, on metformin and atorvastatin, has elevated AST and ALT, and a transient elastography score of 12 kilopascals. Patient was started on resmetirom 12 months ago, and now her transient elastography is 7, and her ALT has normalized. Her BMI and hemoglobin A1C are unchanged. Which of the following would be most appropriate as a next step for her? Number 1, continue resmetirom and recommend treatment with semaglutide. Number 2, initiate or switch therapies for cardiometabolic comorbidities if they worsen. Number 3, stop resmetirom and perform bariatric surgery. And number 4, suspend treatment with resmetirom and recommend tirzepatide.
Do you green team focus? This is $800. Let's catch up. I see some of the green teams not answering that question. That was $800. Please.
All right. Yeah, go ahead. Sorry.
The answer is to continue because they had adequate response as far as the resmetirom goes, but if you notice, the A1C and lipids did not improve and their weight did not improve. So the semaglutide would be a great addition at that point, or GLP-1.
Oh.
Yes. All right. Green, you keep not voting. That's good. This is a trouncing.
All right.
That's painful. Let's do less pain for 100.
You need less pain. All right. Which of the following NIT pairings is the least useful in determining risk for advanced fibrosis? Number 1, ELF and transient elastography. Number 2, ELF and MRE. Number 3, FIB4 and ELF. Number 4, FIB4 and AST to platelet ratio index. Least useful. Yay.
That's you.
That is correct. If you remember, I didn't even mention the APRI. We don't do it anymore in MASH. It's less studied.
That's so
But in
1990.
general, 2 NITs is helpful. We talked about that. We start with FIB4, and then you follow it either with the ELF or transit elastography. If you want to take it a step further, you go fancy like Dr. Watt in Mayo Clinic and you do MRE. But the APRI was more used with the hepatitis C data than the MASH data. There's some data, but it's that's the only one that is not that great combo. And let's see the answer.
Oh, green.
Green.
Still $1,000 away.
All right, we're going to do buy the book for $800.
Oh, you're going back. Green, this is 800. It's 800.
Oh, and a daily double. Ooh. Pressure's on.
Yeah.
Oh, pressure is on. All right.
Excuse me, green team, wake up. Can you do this? Green team, please. Focus on this. Please, green. Thank you, green.
Oh.
It's double.
Uh-oh, what happened?
We're going backward.
All right. Patient with transient elastography of 7.6 kilopascals has poorly controlled type 2 diabetes while taking metformin. His BMI is 28. He's on lisinopril for hypertension. Which of the following is the most appropriate next step for him to reduce weight and better control his type 2 diabetes? Number 1, suggest a switch from metformin to semaglutide. Number 2, suggest increased dose of metformin. Number 3, add tirzepatide to the metformin and start resmetirom. And then number 3, start resmetirom.
$1,600, right?
This is the game changer time.
This is.
Come on,
800 daily double.
Guys, green, get it, please.
So it is the switch from the metformin to. What?
Show me the money.
Not.
Show me the money.
Not.
Show me
Not.
the money. Now you can say the answer. I'm going home.
Yeah.
That is 4,000 something. I don't know what we're.
Now it's 4,000.
It's a Louis Vuitton now.
Yeah.
Okay. Let's,
Yeah. Oh, so this is just soul crushing. I can't even read the answer now.
Do you want some water?
Yeah. Yeah, I might need something stronger than water after that. Devastation.
Oh, look
Utter
at that.
devastation. Utter devastation. All right, let's get this game on.
Keep it up, guys. Keep it up, guys. We're going shopping after this. Let's go buy the book 600. 3 to go.
All right, which of the following NIT results indicate a patient is eligible for treatment with resmetirom? Number 1, ELF score of 10.2 to 11.5. Number 2, MRE 2.67 to 3.3. Number 3, transient elastography 8 to 15. Number 4, platelets less than or equal to 140,000. Nice job.
All right, let me tell you why you should not go for 1. If you see the ELF is too high. To 11.5 is way too high. So you're gonna touch the cirrhotics and even our risk of decompensation. The KPA and the MRE less than 3.3, it's too low. That's when F2ish starts. The ASLD guidance talk about 8 to 15. Actually, it's extend on the text a little bit beyond that, all the way to 20, but you should not have a platelet less than 140 because this is when you start thinking more cirrhosis and thrombocytopenia, and that's why platelet less than 140 is also not an answer. Go green. All right, so.
Yeah.
Oh, yellow came back.
We're creeping back.
Keep it
dear.
spicy.
Oh dear. Oh
right.
dear.
Oh.
All right, we're mishmashing
Oh,
for the
we have-
400.
Yep. All right, which of the following is true of MASLD and cardiometabolic comorbidities? Number 1, increasing number of cardiometabolic comorbidities is associated with increasing mortality risk. Number 2, alcohol consumption minimally impacts MASH outcomes. Number 3, patients must have at least 4 cardiometabolic comorbidities to face a risk of advanced fibrosis. And number 4, statins should not be used in patients being treated for MASH.
Wow,
Yay!
we don't even need to talk. We don't even need to talk. Let's move on to the next one.
This is close.
Oh, but then this is going to be, yeah.
There's no way somebody wins that now. What are you doing back there?
You give it to green.
How? How?
Doesn't matter. We won.
No. I want to recount. The math ain't adding up.
You sound like Trump. I'm just kidding.
All
Mash,
right.
mishmash. Who won the election? Mash, mishmash, 800.
Last one.
Okay, one more. We get 100% again. I don't know.
Which of the following is the most appropriate course of treatment for a patient diagnosed with F4 MASH who has a BMI of 24, hypertension, and dyslipidemia, and is taking lisinopril and atorvastatin? Number 1, suggest treatment with GLP-1 targeting therapy. Number 2, initiate treatment with resmetirom. Number 3, stop the statin. Number 4, weight management and exercise.
This is the finale. This is what
Last
is...
one, guys. Last one.
Yes, go green. Focus first. Answer the question and then... Craig, answer the question correctly.
This should also be 100%er.
Oh. No.
All right.
So maybe we can have a discussion about this.
It's
Yeah.
so
Best you start talking.
Why? Because
Yeah.
this is cirrhotic patients, so that's the key. There's no approved therapy for mass cirrhotic. It's resmetirom trial is still ongoing in mass cirrhotic, so it's not indicated in mass cirrhotic. SEMA, if it gets approved, the study, the ASCENT study, is F2 and F3 studies. So Dr. Watt talked about stopping the statins. We don't stop, we like the statins even in early cirrhotics. It actually has a lot of data on HCC prevention as well as maybe prevent decompensation. And if they need it, they need it. So it's the only option is weight loss and exercise. And fingers crossed for the next screen.
Yes.
Oh.
Yellow. All right. They tried to steal it from us, but there was no chance. But we've got some questions.
All right. So just the concluding slide. So MASH is a progressive disease. It's closely linked to cardiometabolic comorbidities. Identifying and staging fibrosis is now done through non-invasive tests. We do not use a liver biopsy typically. Resmetirom is the first approved treatment for MASH and is currently approved for patients with stage 2 and 3 fibrosis. GLP-1 targeting therapies are helpful in controlling cardiometabolic comorbidities and have shown beneficial effects in MASH. And then remember that bariatric surgery is still a viable option for managing obesity in patients with MASH. Okay. All right, so I'm going to ask a few questions for the group.
That's you.
All right, you want to
Okay, so there's an announcement I'm supposed to make here, or you probably are, but I'll read it. We've been made aware that the evaluation form is missing a line for your name, so please be sure to add your name on the top of the form, and email is added on here too.
Oh, sorry, the post-test question. Okay, we'll do the post-test question and then we'll do the Q&A. So in approximately what percentage of patients with MASH and cardiometabolic comorbidities will you now prescribe a GLP-1 targeted therapy to? Number 1, 1. Number 2, or none, sorry. Number 2, 25%. Number 3, 50%. Number 4, 75%. Number 5, 100%. And number 6, I don't manage patients with MASH. Okay, so we have, here we can see the answers to the post-test question.
Exactly. Spin it off.
And then, all right, so now we have a couple of questions.
Good luck with that one.
All right, do you want me to read that? Or
I can read this
Okay.
question. It's a bit not clear to me, but I think the question is about the MASLD or MAS cirrhosis and differences in intervention. Because I didn't understand the question, let me tell you the story of MAS cirrhosis. We do not have therapy for MAS cirrhosis as of today. There are multiple clinical trials that have been negative in MAS cirrhosis. It's harder disease to treat. Its fibrosis is more. There's data that is supposed to be presented. There was a press release that one of the FGF21s reversed cirrhosis or decreased fibrosis stage by 1 in cirrhotic patients. So we're hopeful that more agents down the road, especially for longer duration, will reverse MASLD cirrhosis. So the sky is the limit here.
Okay. Do you want to go next?
I have a couple here, but you've got a few.
Okay. So what, and this can be for any of us, what would be your primary choice for a patient with MASLD who has a BMI of 23, F2 disease, high cholesterol, and hypertension? So I think this would be a good candidate for resmetirom. You know, they're not overweight, they don't have diabetes, but they have stage 2 fibrosis, so they're moving along that disease spectrum. I would probably target more use the more liver-directed therapy and start resmetirom.
Yeah, I'll often also tell the primary care team that if you are treating high triglycerides, high lipids, high LDL, obviously we talked about the statins, that please do use those. And if you needed triglyceride therapy, there's some benefits to fish oil for some anti-inflammatory properties. It's got, you know, at least some animal data that there may be an impact liver-wise. It's not proven, but there's no big liver-related downside to it. And if they're going to choose a fibrate, to use one of the ones with PPAR activity, because there can be some potential benefit there too. So to choose like a fenofibrate or one of the ones that has PPAR activity, if you're going to help them choose the optimal lipid agents. So there's one here that is like, if therapy is successful, could this be lifelong? And I'm assuming you're meaning a GLP therapy, or is it resmetirom? I'm not sure. Resmetirom, okay. Nobody knows the answer to that question yet. So there really isn't, that's one of the biggest questions we still ultimately have is when do we stop? And I think as long as you're still seeing benefit as far as looking at the metrics to treatment, then carry on. But nobody quite knows that answer yet, so to be answered someday.
Yeah, and I think we have to remember that just like hypertension, diabetes, MASLD, and MASH is a chronic disease. So oftentimes, whether it's a GLP-1 or resmetirom, they may need long-term therapy, but we'll see what the data shows as time goes on. All right, and this can be to anyone as well. Could you review the side effects and contraindications to resmetirom and any advice on getting insurance approval for patients? I don't know if one of you wants to take that.
GI side effects, nausea, diarrhea, they usually start within up to 9 days, and they're on the mild side. Some patients have a little bit more diarrhea than others, and then they subside with time. Insurance, there is, I think, there are specialty pharmacy that they are supposed to help you. Sometimes we get on the phone and have peer-to-peer, but as you know, insurances will vary. It's important to document if your patient has significant advanced fibrosis. Do these transient elastography numbers. Sometimes they don't understand it. Use that word significant and advanced fibrosis. They will understand it better. But it's going to vary. Persistency, I guess.
Yeah, I think it's the wording of the documentation. So significant advanced fibrosis, document what, that they have stage 2 or 3 fibrosis. And the other thing that I found that helps is also writing that they are also working on lifestyle modifications, because the official indication is in conjunction with lifestyle modifications. So I always write that, like that's the recommendation, resmetirom in conjunction with lifestyle modifications. I don't know, these little tidbits sometimes help, sometimes don't. It really is patient dependent though.
Any more questions?
This one's a really easy one. Is it coffee or caffeine with the liver impact? And it's actually not the caffeine. It's pretty much everything else that's in the coffee. So the antioxidants, the phenols, the xanthine derivative, all the other stuff, not specifically the caffeine.
Okay. All right, this is kind of a loaded question. As a gastroenterologist, should we take ownership of prescribing GLP-1s?
Should is a hard word. Could we? Yes, absolutely. If they've got diabetes, I'm probably not the right person to be monitoring their diabetes, right? And so I think that's usually my decision point, is if they're diabetic, they have an endocrinologist or a primary care that's dealing with their diabetes, they're going to be titrating things. It's just not something that coming every 3, 6, 12 months is appropriate to be managing. So that's my usual.
I think we will. If we have, with SEMA, eventually, if we get approval for NASH and F2 and F3, they will knock on your door, and we need to know about it. There's also survodutide with it, which is GLP-1 glucagon dual. So we need to familiarize ourselves with these medications, because it will likely be in our GI and liver offices. So I'm kind of, used to it by now, because I tried with weight loss and stuff like that. I do understand. I get a little bit confused with it, with if the patient is on insulin, but now a lot of people are, fading away from insulin, and we have more advanced therapies. So short answer, I think we will eventually cross that bridge.
Yeah, and I think, the one thing, because this is a cardiometabolic disease and, patients have multiple cardiometabolic risk factors, we're going to have to do everything in conjunction. It's really going to have to be a team-based approach. So if they have diabetes and we don't want to, mess with that stuff, we at least recommend that they be on a GLP-1, because maybe we'll have an indication in the near future. All right, next question. At the 3-month check after initiating resmetirom, what level of transaminases would you consider to stop the medication?
There's no recommendation to stop the medication at 3 months based on liver enzymes. What the documents say, you might want to check at 3 months. A lot of patients will ask you after starting medicine. You might want to check at 6 months. I do check at 3. I do check at 6. I do transient elastography at 6, not at 3, and the trial was for an entire 1 year. So as the other medications in the pipeline, the efficacy is proven around 1 year, even longer sometimes. So when you decide to look at the efficacy, it's at year 1 at least, and what you want to see 20% or 17 years drop in ALT, and that's not the only reason why you should stop it. You probably use a couple of them, like transient elastography by 25% or ASLD, use ALT and look at the totality of the NITs data.
All right.
Is that it?
I think so.
All the questions?
All right, thank
you so much.
One more question, hand up. Oh, can you yell?
You know the last case you presented, the BMI of 24?
Mm-hmm.
That would fall into the category of lean NASH, is that correct?
Mm-hmm.
Yep.
So what advice, I have several skinny Asian women who are like 100 pounds with NASH, and you tell them exercise and weight loss, but I don't know how much exercise, how much, because they're already 100 pounds. So talk about exercise and weight loss, I'm not sure what to advise them.
Yeah, so those are a little bit tougher, but lots of times it's abdominal adiposity that kind of goes with it. So at least some weight loss. It's hard to give them an exact number. You can defat the liver with resistance exercise and cardio exercise as well. So I usually focus a little bit more on the exercise component and trying to go with the low fat, make sure they're LDL, all the other cardiometabolic stuff and not insulin resistance, all that sort of stuff as the driver. And then looking for other things that can be associated with lean MASH, which is, lysosomal acid lipase, DHEA, all these other sorts of things that you want to make sure you rule out. Anything else to add?
If they have fibrosis, you need liver-directed therapy.
Yeah.
I think the last case was cirrhotic, so we don't have therapies. I think we said weight loss and management, and as Dr. Watts said, there's lean NASH guidance in the AGA. It says 3 to 5%, but again, 100 pound is, as she said, you see this little bit belly at central adiposity, which they can work on.
Yep.
Thank you
Great.
for the
Thank
question.
you guys
Thank you,
for
everyone.
attending and sticking it out. Good, great job. Yellow winners.